Malformations. It's my pleasure to introduce Dr. Chad Wallis, our Chief of Pediatric Urology, for his lecture on Anorectal Malformations, Urologic Considerations. Thank you, Dr. Wallis.
Thanks. Welcome, everyone. Glad to be here. I have no relevant disclosures for this lecture. I wanted to start off by asking a poll question to find out what the experience has been, particularly of the fellows that are on the call today. So if you'll just let me know how many posterior sagittal anorectoplasty operations, and I would include a cloaca repair in there, not a UG sinus, but a cloaca repair, have you scrubbed in for during fellowship? And we'll say either none, 1 to 2, 3 to 5, or more than 5. We'll give you a few seconds. We can come back to that. I'm going to move on to the next slide, though. I think that it's important to learn about anorectal malformations because even if you're not at a big colorectal center, you're still going to run into these patients and work with them. So it looks like about a third of the fellows have done none, 25% have done 1 to 2, and then a little over a third have done more than 5. So there's a good mix there of people. One of the reasons that I think it's important to learn about anorectal malformations is that there are a lot of associated abnormalities of the urinary tract with these patients. And some of them are anatomical, they're related to their anatomy. Some of them are functional abnormalities, and some of them are acquired because of the repairs that they've undergone. There are also gynecologic considerations, and in many programs, the urologist will take care of and help with managing gynecology issues if you don't have a full-time pediatric and adolescent gynecologist. And urologic complications are also common in these patients. And finally, I think that wherever you end up, a multidisciplinary approach is really best for evaluating and managing and long-term follow-up of these patients. So what is the role of the pediatric urologist? Like many patient populations, our primary role is really to preserve renal function, and I have found it's not always something that the pediatric surgeons are keyed into as well. And so you can really advocate for preservation of renal function for these patients if you stay involved with them. You can help them to restore normal anatomy, particularly when it comes to the urinary tract. You can help with managing bladder function and incontinence, which a lot of these patients will have. Prevention of urinary tract infections is another area where we play a role. So in terms of background, there's a really wide spectrum of defects. And again, it often also affects the development of genitourinary structures. Our current terminology is based on location of the rectal fistula, which typically has prognostic and therapeutic implications. The incidence is about 1 in 4 to 5,000, so it's a fairly common issue. There's a slight male dominance. The most common defect in males is a rectourethral fistula. For females, it's a rectovestibular fistula. You can see imperforate anus without a fistula in about 5% of cases, and it's more frequently associated with patients who have Down syndrome. So for classification, here's another poll question for you. This image demonstrates a high fistula, a low fistula, a rectourethral fistula, or a cloaca. I guess I'm supposed to wait 20 seconds. This is the long, awkward pause. Okay. So yeah, it's a rectourethral fistula. We fooled a couple of people, but yeah, the classification of high and low really is not used anymore. It's a historical classification. Again, there's a broad spectrum of these defects. We try to base it on the anatomic location of the rectal fistula. The more proximal the location of the fistula you're more likely to have poor prognosis in terms of bowel control, a greater likelihood of sacral abnormalities, and a greater likelihood of urologic abnormalities as well. So some of the associated malformations, this will go back to your medical school days. Everyone remembers learning the Vactral syndrome and association. The incidence of this in anorectal malformations is a little over half of them will have at least 3 or more anomalies consistent with Vactral. 3 or more will have, about 8 to 10% of patients will have 3 or more anomalies consistent with the Vactral syndrome, and the incidence of having some kind of associated abnormality is about 50 to 60%. Sorry. So about a third of them will have some kind of cardiac abnormality. A third to a half of them will have spinal or vertebral abnormalities. This is really important, I think, for the urologist to look at, because at least in our practice, we like to do baseline urodynamic studies in those patients that have spinal and vertebral abnormalities. They're, again, obviously going to be more likely to have a neurogenic bladder, and those patients really do need long-term urologic follow-up. And then genitourinary anomalies in about a third to a half of these patients, and gynecologic issues in about a third of them, GI issues like the TE fistula in about 5 to 10%. So here's the last poll question. What is the most common congenital urologic diagnosis associated with anorectal malformations? Either a solitary kidney, ectopic ureter, vesicoureteral reflux, or hydronephrosis. Okay, so actually it's going to be hydronephrosis. If you think about it, common things being common, hydronephrosis is sort of the most common abnormality that you're going to find in any of these kids. This is some data that came from an SPU abstract that Molly Fuchs presented in 2018. I actually emailed her yesterday, and she has written a manuscript and submitted it, and now has like 700 patients. But this was published with the SPU abstract, so I included this table, and you can see up here that in terms of hydronephrosis, for both females and males, we're going to kind of discount the vaginal fistula, but the incidence goes up higher with the more severe the abnormality, and the same is really true with the males as well. And it's by far the most common diagnosis. Many of them do have reflux, though. So anyways, I thought that was good data that she came up with. The other thing that you'll find the pediatric surgeons talking about a lot is the sacral ratio. And so they'll get pelvis films, and they look at these landmarks and create a ratio from these landmarks, the tip of the coccyx up to this notch on the, I think it's the iliac notch, and then the iliac crest up here. And then a ratio of about 0.7 is normal. If it's less than 0.7, then it tends to have a poor prognosis. So a ratio of less than 5 is associated with more severe malformations and poor prognosis for bowel control. Most of the surgeons will tell you, if you talk to Dr. Pena or Mark Levitt, that they've never seen anyone with good bowel control that has a sacral ratio less than 0.3. So that's something that they point to in terms of bowel control. And again, with a abnormal sacral ratio, we'll typically get those kids in for baseline urodynamic studies and try to follow them more closely. If you have a hemisacrum, then you need to think about a presacral mass. And again, this is more for the pediatric surgeons, but they're going to be thinking about teratomas and lipomas and things like that. Okay, so I'm going to move on, and we'll talk a little bit about ARM and boys. I know a little bit about boys because my wife and I have 5 boys. We could never get a girl. We finally gave up. This is a picture of a couple of years ago up at Yellowstone. And then we'll talk a little bit about ARN in boys. So let's move on. So male defects. You could have cutaneous perineal fistula. And sometimes these kids, you won't even do a colostomy on them. They'll just dilate that fistula and then do an anaplasty at a later date. And then rectourethral fistula is the most common. You can have going to the bulbar fistula or prostatic, the bulbar urethra or prostatic urethra. And then a rectobladder neck fistula is kind of the more severe case. And then you can have imperfect anus without a fistula, which is more common in the Down syndrome patients or rectal atresia. So here's a couple of examples for you. This is a perineal fistula. There's a few variations on this. This one, sometimes they'll have some unusual kind of skin tags. This guy has this little kind of skin tag here. You'll see these epithelial line tracts that are sometimes filled with meconium or mucousy stuff. There's another little kind of thing there, some meconium right at his perineal fistula. And these kids get a primary anaplasty typically. So let's move this fistula down kind of into this sphincter complex. So here's some artist renditions. I think these are helpful to see the sagittal view because you can see where the defect is. With some of these higher fistulas, they'll actually do a laparoscopic repair and dissect down through here and then disconnect the fistula from there and then do a pull through that way. One of the other things that you'll see these guys get is a distal colostogram. And people like Dr. Pena and Dr. Levitt really feel strongly that this should be a high pressure colostogram so that you can actually, you actually want to see that fistula there so that you kind of know where it enters. Because you're going to do a lap repair on this kid, but you probably are going to do a posterior sagittal anorectoplasty on this kid. And you want to know ahead of time what your best approach is going to be. So this is a study from 2002. It was Dr. Pena's series. Dr. Levitt was on this paper as well. There are two groups. The group A here is patients who underwent primary repair by Dr. Pena in New York. And group B was 431 patients who got referred in after their primary repair. And so you can see the different kinds of injuries that can occur with these patients. Neurogenic bladder here in 27, a posterior urethral diverticula, urethral injuries, divided vas deferens. So things are going to happen with these patients that you may need to be involved in. One of some of the important points to avoiding a urologic injury is, again, that high pressure distal colostogram to really know where the fistula is so that you can make a good plan preoperatively. And then a Foley placed at the time of initial surgery, you sort of think, well, that's obvious. I'm a urologist. I would always place a Foley at the time of surgery, but some of the peds surgeons have not always done that in the past. I would say now they're probably better at doing that, but that's where injury has also occurred because you get confused and are not sure where you are without that Foley there. And then consider cystoscopy. I've done cystoscopy a couple of times intraoperatively where they've called me in and said, hey, we're not sure exactly where we're at. Can you throw a scope in there and take a look for us and see if we're in the right spot? And it's been very helpful for them. Or sometimes we'll do it preoperatively so that they can have a better idea of the anatomy. And that's been helpful for them as well. Urinary incontinence can be an issue with these guys as well. Very uncommon in the perineal fistulas. You'll see a little bit in the bulbo-urethral fistulas, but again, the more severe those defects go, the more likely it is that that they're going to have trouble with urinary incontinence. And the bladder neck fistulas, almost 20%. And then this is always kind of my last reminder here. If you have a kid that's got a sacral abnormality, you need to make sure you follow that kid long-term and evaluate them for neurogenic bladder. So again, we don't have, the only girl in our family is my wife. So here's a picture of my wife. We rode bikes. This is from a couple of weeks ago. You still see a little bit of snow up in the mountains there. So that's my girl picture. Female defects. So you can have a perineal fistula with these guys again, where it's cutaneous. A vestibular fistula. You can have imperforate anus without a fistula, just like in boys. Rectal atresia, and then cloaca. And most people will divide these into patients with a long channel versus a short channel, and the cutoff is typically 3 centimeters. You'll see that in the literature and in textbooks, and we'll talk about why. And then other complex malformations as well. So here's a perineal fistula. Again, with these patients, oftentimes some perineal dilation will work well for them, and they don't necessarily need a colostomy right away at birth. And then you can do a primary anaplasty at a later date. This is a rectovestibular fistula, so it's a little higher up. About 17% of these will have gynecologic abnormalities like a vaginal septum or an absent vagina or an absent uterus, for example. Here's a picture where you can actually see the vaginal septum here. So here's the fistula right here at the vestibule, and then you can see the 2 hemivaginas with the septum in between. And then this patient has vaginal atresia. So here's kind of your typical short channel cloaca on the left side. So there's a short common channel, and you can see there's a nice long urethra. And then here's a patient with a longer common channel on the right side. A lot of these patients will actually have hydrocolpos. So in terms of their newborn management, it's important to evaluate for this. And if you do have a patient with cloaca, getting a pelvic ultrasound is helpful to rule this out. You also have to be careful, because if you get one like at 12 hours, they may not be producing enough urine to really demonstrate hydrocolpos. So you need to keep an eye on them because they can get distended over time. And you can get hydronephrosis and hydroureter because this fluid will build up and cause compression on the trigone. And oftentimes, if you manage that properly, you'll get improvement in the hydronephrosis and hydroureter. Many of them also have duplicated Müllerian remnants as well. And we'll talk a little bit more about that. So hydrocolpos occurs in about anywhere from 1/3 to 2/3 of cloaca patients. The numbers are a little bit over. It's retained urine. The urine preferentially will go up into the vagina instead of out through the common channel. You'll also get secretions from the maternal estrogens that will cause some mucus production in the vagina, and it can lead to obstruction, like we talked about. There's a couple of different ways to do decompression. One of the simplest ways is to do intermittent catheterization. Frequently, the catheter will preferentially go into the vagina anyways. And so you can do intermittent catheterization on these patients and decompress them that way. And for many patients, that works pretty well, and the parents can be taught to do that. The other option is to put in a pigtail catheter, and you can actually leave those in for 6 months or more. We've left them in for a long time to allow for decompression. I have, in one patient, I did do a vaginostomy like early in my career, and I wouldn't recommend doing that, a cutaneous vaginostomy. They work really well for decompression, but then when you go back later to mobilize the vagina, everything, you've sort of sutured it up there, and freeing it up from it's a real pain. So if CIC is not going to work, then a pigtail catheter is I think a better option. And then you can do some kind of fenestration. Sometimes one of the hemivaginas will drain better and the other one won't. And if you fenestrate the septum, that can help. I haven't really ever done that. I've found that just putting in a pigtail or doing CIC seems to work pretty well. So Mullerian anomalies. A double Mullerian system is seen in about 40% of patients. You'll see 2 hemiuteri, 2 hemivaginas, and you can see some asymmetry where one will be kind of a rudimentary uterus with a really crummy looking cervix, and the other one will actually look pretty healthy. So you can see some variation there. And then the vaginal anatomy is also variable. Frequently, when you have 2 hemivaginas, they're side by side with a septum that goes vertically right down the middle. But you can see that they're sometimes rotated in a funny way, that it's not just a septum, but there's 2 separate openings to the vagina. So cystoscopy can be tricky with these guys kind of figuring out where the anatomy is and where everything's located. And then finally, the gynecologist will tell you, and you can see intraoperatively sometimes that you'll get obstruction of these fallopian tubes that maybe have not developed properly. And so many times, particularly if you're doing an abdominal approach in these high ones, we'll try to evaluate the fallopian tubes to see if they're patent. So for radiologic evaluation, a cloacogram has kind of always historically been done, and these are some of the images that you'll see from a cloacogram. And I still think that there's a role for those. I also think that there's a role for endoscopic evaluation. You can see a urethra heading up anteriorly here, and then the vaginal opening, and usually the fistula is just kind of below there. Oftentimes, if there's a septum with 2 hemivaginas, the fistula will typically be located posteriorly right below the fistula is a good place to look for it. We've started doing 3D cloacograms, and these are some of the pictures. This is a patient that I repaired a couple of months ago with one of our pediatric surgeons. So here's kind of the 2D cloacogram, and then here's the 3D model. And I just took a static image, but you can kind of rotate this around and look at the anatomy a little more easily. It gives you a little bit better definition, and it's very helpful. They can also get some measurements of the common channel length as well as the urethral length, which is important. And we'll talk about why that is. Endoscopically, we've always in the past measured these with our cystoscope, and it's usually you put your cystoscope in and get it right at the confluence, and then stick your finger kind of at the perineum and pull back and measure where your finger is on the scope with a little, it's kind of a ghetto way of doing it, but it does tend to work pretty well, actually. And this patient, you can see on here that the measurements of the common channel were common channel was 3.3 centimeters, and the urethral length was 1.8 centimeters. Endoscopically, my measurements that I wrote down were common channel of 2.2 centimeters. So I underestimated the length, or they overestimated the length, but my measurement of the urethral length was also 1.8 centimeters, actually. So we were kind of right on the money there. And this is a patient with a flat bottom. You'll hear the pediatric surgeons talk about a flat bottom also. You really can't see any sphincter complex at all. These patients don't really have a good prognosis in terms of bowel control. So if you have a long channel, then these patients more likely will require a laparotomy, concomitant laparotomy, to mobilize everything. They're more likely to require some kind of vaginal augmentation or replacement, including like a vaginal switch or reconstruction with a neovagina with rectum or sigmoid colon or ileum. I've got a couple of drawings of those. So this is a patient that's got 2 hemivaginas, and they're both good size. I've actually never done this, but I've seen these images. It's a cool concept that Dr. Pena came up with. And so you really you have to sacrifice one of these uteruses, and so you try to pick the one that's more rudimentary, and then you'll take this one and kind of flop it down um, to help it reach the perineum. Obviously, you're going to have to do some um, mobilization from above. This can't be done from behind. You can do reconstruction with rectum. I've never done this either, but if they have a large dilated rectum, which some of them do, you can use a portion of that, keeping the mesentery intact. It's really down there, very close, and would be a nice way of doing it. We have more commonly just used some colon and mobilized a piece of the distal colon and brought it down to work as a neovagina. So for these females, you know, a lot of them will need clean intermittent catheterization, particularly if they have a longer channel. Some of that has to do with the way that they're repaired. Many of them actually do have a competent bladder neck, but they have a flaccid bladder. And again, you want to watch for the sacral abnormalities to rule out a neurogenic bladder in these patients. So this was a paper from 2010 from Dr. Pena and Dr. Levitt on lessons learned from nearly 500 cases of cloaca. And they had two different groups. They had group A with a short common channel, and then group B were the longer common channel. And so obviously the longer common, you can see the operative time was 3 hours versus 6 to 12 hours. It's a much more technically challenging case. A much lower percentage of them had voluntary bowel movements, and only 28% of them actually had urinary continence in the longer channel cases. So they came up with this nice algorithm. This is a nice paper to kind of refer to how they did their algorithm for these patients, and it was really based on the length of the channel. If it was greater than 5 centimeters, then they would just start with a laparotomy. More recently, though, out of Nationwide's, where Dr. Levitt moved to and created a colorectal center there, they've been looking at the role of urethral length in these cloaca repairs. It was actually really interesting. They have done some work looking at VCUGs and determining what is the typical urethral length in females, and it's about 1.5 centimeters is what they found. They also kind of looked back at some of their complications and complications that they got from other centers, and it seemed to be that these patients with shorter urethral length tended to have more problems with continence. So you can see their 2D cloacagram here, and then we had our ghetto 3D cloacagram. This is what you get when you go to Nationwide. You get this like color-coded 3D cloacagram. We can't really compete with that, I guess. That kind of tells you where the anatomy is. And then they came up with a new algorithm, and they do things differently based on the length of the urethra. And I'm going to show you why. So you'll see here that if it's less than 1 centimeter, the common channel, then you can usually just do a PSARP and that'll be fine. If it's 1 to 3 centimeters and the urethra is normal, then you can do a total urogenital mobilization and a PSARP on those kids. But if it's less, if at any point you find a urethra is less than 1.5 centimeters, then they'll do a UG separation procedure. And I'm going to show you why that's important. So I hope this comes up okay. We're going to focus mostly on this top picture here. So when you do a total urogenital mobilization, or when you do a urogenital separation, what you're talking about doing is dissecting the vagina away from the posterior wall of the urethra. So you basically sew this closed, and this common channel is used as the urethra. You just leave it intact and that becomes the urethra. Then you have to mobilize that vagina and either bring it down to the perineum here or create a neovagina with a bowel interposition graft. So that's what you want to do with a short urethra. Where you get into trouble is when you sort of say, I think that I can probably mobilize this, and let's go ahead and do a total urogenital mobilization on this patient. And so you dissect all the way through here, you dissect along the anterior wall of the urethra, and then all of a sudden you go, oh no, it's not going to make it. And then you decide, I'm going to have to separate this. So now you do this dissection along the posterior wall of the urethra as well, in order to kind of salvage the issue. And what we find is that anterior dissection followed by posterior dissection of the urethra is going to cause ischemia, and you'll suffer urethral loss. And I've seen a patient with this in my practice, and that's one of the things that they saw when they looked at their data as well, which led them to sort of say, you know what, if the urethra is less than 1.5 centimeters, let's leave that anterior part intact and just separate the vagina off of there so that we're only dissecting either anteriorly or posteriorly. And that's why, you know, working these kids up with good imaging and cystoscopy is really helpful. Okay, I want to spend the last couple of minutes talking about creating a colorectal program. I know a lot of you are at great centers that have an amazing colorectal program already, but you could be taking a job at a place where they don't have much going on in terms of a multidisciplinary approach, and you know what goes into doing this. So our experience began in 2011. Oh, this picture was taken today, by the way. I just wanted to show you that. So you can see our state capitol right there. There's downtown. You can kind of see the Great Salt Lake out there. So it's looking nice right now in the spring. So the goals of creating a program are to improve care, outcomes, and quality of life for patients and their families, to have kind of a unified approach of initiating care at birth, getting multiple specialties together to create a team approach and be able to coordinate care. It's helpful for bowel management later on in these kids, and it will help provide long-term continuity of care. In our clinic, I mean, every clinic is a little bit different, but we definitely see anorectal malformations and perforated anus. They also focus on Hirschsprung's disease and other issues related to the colon and rectum, like idiopathic constipation, fecal incontinence, you know, other stuff like that. And each center will decide kind of what they want to see and what you don't want to see. So we started in 2011, and we decided, we traveled around. I actually took the Pena course. Our pediatric surgeon spent some time at Cincinnati Children's when Dr. Pena and Dr. Levitt were still there. We had Dr. Levitt come out here a couple of times and do some surgery with us, and really leaned on his experience to figure out how we could make a good clinic. So we started by holding monthly multidisciplinary meetings and discussed new referrals, organized studies and physician visits, went through surgical planning, and tried to prioritize our interventions so that we would do the least number of operations. We reviewed all of the imaging studies together and made careful plans, and then provided long-term follow-up. And this led actually to a creation of processes and protocols that help to streamline our patient care. And now we actually meet quarterly to discuss the most complex patients only, because some of the more straightforward patients, we already have processes and protocols in place that we can follow through with them. And so we're not having to discuss every single patient that comes through. We started out with having surgery in urology. Neurosurgery was coming down regularly. We had wound and stoma therapy as well as nursing. We've had gynecology off and on. I don't think we're alone in saying we've struggled a little bit with getting some consistency there. I think there's some programs out there certainly that have great consistent support from gynecology, but we have not had that yet. However, we have added social work, and we're getting a gynecologist in the fall of this year. Our neurosurgeons don't check in, and we've found that, you know, although a lot of these kids have abnormalities, it just hasn't worked well for our clinics, so they get seen kind of on a PRN basis. Same with wound and stoma therapy. Our nurse coordinator, nurse practitioner, who is our clinic coordinator, quickly became very competent at a lot of these issues, and now we have 2 full-time nurses who are also have become very competent, and so we don't find that we need to have someone from wound and stomal therapy every time. Our clinic visits started about 8 per month, and now we see about 44 patients per month. So it's grown over time. In terms of the coordinated procedures, we typically do cystoscopy on male patients with rectourethral fistula prior to their PSAR, but not necessarily on the perineal fistulas. We'll do cystoscopy and vaginoscopy on all of the cloaca patients, and we coordinate both of these together with the pediatric surgeons. And then the 3D cloacogram requires placement of catheters in the vagina as well as the bladder. And so in order to do that and make sure you're kind of in the right place, you really need to do cystoscopy. So we'll do that together with examination under anesthesia, and then wake the baby up and send them downstairs to imaging for the 3D cloacogram. And we've developed a process for doing that that works pretty well. The clinic coordinator, obviously you guys have done probably enough multidisciplinary clinics to know that this person is key. You've got to have an amazing person, and we're fortunate to have someone like that. One person for patients to call with concerns, who can coordinate treatment plans between the specialists and really oversee the entire patient's care. They can order and schedule needed studies for clinics. So you don't want this person to be an MA, you want this person to have, you know, the ability to order things for you and schedule things. And then they're a point person for bowel and bladder issues, including she can shoot me a message and say, hey, this person had a UTI and an ultrasound recently, can you take a look at it? And we can make recommendations for treatment or prophylaxis pretty seamlessly. Some of the lessons we learned over time is it's important to kind of identify the patient population that you're targeting by diagnosis. You don't necessarily want to have pediatricians just sending constipated kids to your clinic. You really only want the challenging patients. You want to have dedicated team members who are going to be there all the time. It really has been helpful to create care processes, and you want to make sure you sort of start small when you're first doing this. And then we found it critical to use mentors and to try to model our program after other programs. There's no sense in reinventing the wheel. You can use the mistakes of our program and other programs to build it better. And then you have to think about long-term management. These really are your patients for life. In urology, we actually, I think, do a better job of having transition services in many centers, but on the surgery side of things, there are very few adult surgeons who are comfortable taking care of these patients, and so they oftentimes end up being followed into their 20s and later. There just isn't a good transition plan for them. So that's really my lecture. I have one other thing I'm going to try to just momentarily. I'm going to stop sharing here for just a second because I wanted to show you one more thing here. And that is the pediatric, can you guys see that? Neha, are you seeing this web page?
Yeah, it's the PCPLC registry.
Okay, good. So this is the Pediatric Colorectal and Pelvic Learning Consortium. And you can see all of the different institutions that are a part of this consortium. And they're creating a multi-institutional prospective database. And you can see, they have 2,348 patients registered. And you can look down here and see what the participation is by diagnosis. So there's over 800 anorectal malformation patients in here. and I and several other pediatric urologists, when they first started this, sort of said, what kind of urologic parameters should we look at? So we're tracking things like hydronephrosis and reflux. We're starting to get better data on urethral length and common channel length for cloacas. And so some of this, you know, it's been a year or two since I've looked at it. The data is going to be mature enough, I think, to get some really good information in the next couple of years. I think where we struggle is like nailing down what do these urodynamics mean. But if you're interested in, you know, an avenue for research, that's an area that you can get into. I'm going to throw this other screen up here real quick because I'll get in trouble if I don't show this little QR code. Okay, so I think that's time, and 5:41, that's pretty good.
That's pretty good, Dr. Wallis. Thank you for that lecture. That was great, and I think there were some really good pictures. I'm going to go through some of these questions kind of in the order of your slides, and then if anyone has any other questions we don't get to, we'll be sure to answer them and post them online. So first, starting out with kind of neurogenic bladder issues, is do you ask the primary service to get a spinal ultrasound on all of these patients, even if they just have like a shallow sacral dimple? Because sometimes they'll say you don't need to if you can see the base. Do we still do that?
Yeah, I had a slide that I didn't put in there, but the initial evaluation typically includes an echo because there are a lot of these patients will have a cardiac abnormality and a spinal ultrasound in addition to a renal ultrasound, and in the you know, cloaca babies, they'll get a pelvic ultrasound. So that is part of the standard workup, is a spinal ultrasound.
Okay, great. And then what age do you do urodynamics on these babies, and how often do you repeat them?
Yeah, so there was a paper out of the Netherlands where they looked at babies, and I think the average age was like 5 months. They looked at it before the repair, and then again at 12 months of age, which is sometime after the repair, because normally you do it between 6 and 12 months. It's hard to know what to make of urodynamic studies in a 5-month-old baby who might be crying the whole time, and where do you put a rectal catheter in a kid that doesn't have a rectum, and what does that mean? So urodynamics are kind of tough. What I usually do is I wait until they're repaired typically, and then I'll get baseline studies after the repair when the surgeon feels comfortable and we can put a 7 French catheter in the rectum.
Okay, and then I guess a corollary to that would be at what age do you do the repair?
Yeah, it's usually about 6 to 12 months of age.
Okay, so then you're doing urodynamics once you have separate orifices for the separate catheters?
Yeah.
Okay, that makes sense.
Yeah.
And how often do you repeat urodynamics?
So it depends, actually. If I have someone that has a significant, you know, sacral abnormality that I'm really worried about, then I'll follow them much like our spina bifida patients, where we'll get annual ultrasounds. Or if I have patients that have very suspicious, you know, a moderate or high risk bladder on my initial studies, then I'll follow them. But if their ultrasounds look okay, they're clinically doing well, and there's nothing really worrisome on their baseline urodynamics, then I'll get them kind of as needed.
You had talked about the sacral ratio and how being less than 0.05 or 0.03 is important for a poor prognosis for bowel control. Does that make a difference in management? Are they like, it's 0.04, now what do they do? Does it make a difference for that?
No, it really doesn't make a difference in management, other than it's helpful in counseling with the family.
Okay.
Yeah, because this family, you know, if you don't want to set them up by saying, hey, we're going to fix this and he's going to be great and he'll have a new rectum and he'll be fine. If their sacral ratio is 0.3, you're going to say, really, we can probably keep him clean with a bowel management program, but he's not going to have normal control.
Okay, that makes sense. And then talking about hydrocolpos, if you're CICing the vagina, how often are parents doing it? And if you're putting in a pigtail, are you doing it, or does IR, and how often does it have to be changed?
Yeah, so we've utilized IR for our pigtails. or sometimes if it's noted at the time of colostomy creation, the ped surgeons can put one in at that time. So those are the two options there. We don't usually change them. We actually just leave them in there. And most of these babies do very well. They'll stay in for 6 months. Occasionally I'll have one that'll fall out and IR can replace it if needed. But we don't typically change them out every month or every 3 months or anything like that.
Okay. And then there's a lot of interest in the 3D cloacograms. So
Yeah.
one question, which is very specific, is what software do we use? And do you need a special machine or device to do it?
Yeah, that's a really good question. I just don't know the answer to that. I would have to find out. I mean, I don't think you need a special machine because I know that we don't have a special machine that we use. I think we use a CT scan that just has software on it. But I couldn't tell you what the software is. You can email me if you want.
Yeah, absolutely. So whoever wrote that question, if you send us your email, we'd be happy to find out and let you know the answer to it. The other question someone asked is how accurate are the 3D images? Like you said, they're different from when we measure, so which is correct?
Yeah, no, I totally agree. I don't know the answer to that. I don't think we know for sure. It would be interesting to figure that out, but then what's your gold standard? I mean, how do you, yeah, I don't know. And I've asked that of our ped surgeons as well. They really like the 3D cloacograms. I mean, they're really into that. And I kind of think it's cool, but I feel like we get as much information endoscopically as we do from the cloacogram. So I think we're going to see where that takes us.
Okay. I think the gold standard would probably be intra-op measurements.
The problem is once you start moving that tissue around and mobilizing the channel and how much do you stretch on it? I mean, I could probably pull it and gain another centimeter out of it, or if I relaxed, it would be a centimeter less. The other thing that you find is that the common channel kind of oftentimes will make this turn and run up along the perineum. And so is that length where it's running kind of anteriorly along the perineum count as common channel length? Because if you split that down ventrally, then the vestibule is kind of right there. And so you're really only concerned about the caudal to cranial kind of distance there in terms of the length of the channel.
I think that's a good segue into some questions about the repair itself. So the first one is not exactly for urology, but I don't know, you might know the answer, is if someone has an anorectal malformation and they don't have a fistula and they're doing this colostomy, what do they do for the blind segment of it? So they bring the colostomy up and then it's usually an end colostomy. What do they do with the other side?
They'll leave it as a mucus fistula.
Okay, so they bring both sides up.
Yeah, so you can do it two ways, and one is to do a loop colostomy, and one is to do a separated colostomy with a mucus fistula. Actually, our institution did a little study because Levitt in the past has really recommended a double barrel separated mucus fistula and colostomy, and a lot of about half of the surgeons at our institution were doing loop colostomies. So they looked to see what the outcomes were between the two, and they didn't feel like there was a big difference. I think the problem you run into is if you make the mucus fistula too far distal, and then you can't mobilize the distal limb down to the perineum, then you get into trouble. And you'll have to take that down. But you can do that with a loop, and you can also do that with an end colostomy as well.
Okay. And then another question related to repair is, do you use your common channel as the urethra or the vagina? I know you had mentioned in one of your slides that usually as the urethra, but is that always the case?
Yeah, if it's a high confluence, and you're going to do a urogenital separation, then you're going to use that channel as your urethra. Now, when you do a urogenital mobilization, a total urogenital mobilization, you've seen Dr. Rink from Indiana has done a lot of great work on this, and you can take some of that common channel to augment the the vagina, or create a better vestibule for the vagina. So you can use that tissue. There's no reason to throw it away. But I haven't seen anyone separate it and use the common channel for the vagina. That would not work very well.
Okay. And then questions about management is, how long are these patients doing CIC? So after they have their repair, are they doing CIC? Are they voiding? What kind of options are there for them?
Yeah, it really depends on the patient. I mean, we had one recently, we did a cloacal repair with urogenital mobilization. It went very well. And then the patient stopped peeing. We took the catheter out and she wouldn't pee. And it took about 6 to 8 weeks. It was pretty stressful because both parents were deaf and only did sign language, and they were in and out of our office. And then we kept working with them, and finally she started peeing spontaneously. So it did seem to be kind of a temporary thing. And so we were fortunate in her case. But in some of these patients, they'll end up doing CIC indefinitely. That's just the way you manage them.
Okay, there's just a couple more. What age do you follow patients up to? So I know you talked about that there's some difficulty with transition sometimes. So ideally, what age would you follow to? And actually, what age do you follow to?
Yeah, we do have a couple of adult urologists who've done recon fellowships. And so we do have a place at our institution where they can go and where we try to transition them to. But again, on the adult side, there's really no place for them to go. And so if they're going to continue being seen in the colorectal clinic, so the more severe patients, then I will see them until they're stopped. Yeah, I mean, there's no end really in sight. We have patients in their 20s right now. Mostly I'm kind of just following things. If they're developing adult problems though, then I'll usually refer them to our adult colleagues.
Speaking of adult problems, what about sexual function in these patients?
Yeah, so we didn't really talk about that, and you know, I should have talked more about that. I don't have a ton of insight into that actually at this point. I think most of the males actually do pretty well, but they can get erectile dysfunction because of disruption of the nerves around that area, particularly with a higher malformation. And then, you know, a lot of the gynecologic issues, particularly with the cloaca patients, surround the same kinds of things you deal with when you take care of patients with a UG sinus or disorders of sexual differentiation where they can have vaginal stenosis. The bowel vaginas produce mucus, so that can be a problem and an issue for them. I don't think we have great data on that yet, to be honest. I mean, I think we need to do a better job of getting some quality of life, particularly as it relates to sexual function outcomes. There's a little bit out there, but not much.
Thank you. And then just the last question is, for a colorectal or multidisciplinary clinic, who is usually the clinic coordinator? Should that be a doctor? Should that be a nurse or a nurse practitioner?
Yeah, at our institution, it's a nurse practitioner. And I actually think that works very well for us because a nurse practitioner has the ability to write prescriptions and do orders and things like, at least in our state, they do. And can do a lot of things that just having a nurse coordinator potentially might not be able to do. Most doctors don't have the time and flexibility with their time to be a coordinator like this. I mean, I think that functions very well. I think a really good nurse would actually do very well also because they can do verbal orders and write in things. And we have 2 full-time nurses who do a lot of that and do a lot of our bowel management. But we felt like it's been a good fit to have a nurse practitioner do it for our clinic.
Okay, great. Thank you. So that's actually all the questions. It's about 5 minutes too, and I think no one ever complained for being done early. So thank you to all of our participants, of course. And then the only other thing I was going to ask Dr. Wallis is, if you're okay with it, is if you would put your email up. If someone wanted to email you a question, you can maybe type on this last slide. If anyone wants to email you any questions, but otherwise, please fill out the survey. That's very helpful to everyone for the lecture series. And thank you to Dr. Kopp, of course, for coordinating all of this.
Yeah, sorry.
Okay, while you type, I can just say it because it's very easy. It's Chad, C-H-A-D, Wallis, W-A-L-L-I-S, at HSC for Health Sciences Center, .utah.edu. So if anyone has any other questions, or if we didn't answer your question completely, please feel free to email Dr. Wallis. Oh, nice. And he can answer your question. Thank you very much.
Thanks, everyone.